So tonight I'm going to go over some minimally invasive treatments for hip pain. And I'd like to start by going over some of the anatomy of the hip joint so you know some of the terms that I'm saying. And then I thought it might make it easy if we could break hip pain up into the location. Some people have pain deep in the front or the anterior part of their hip, the side or the lateral side of their hip, posterior or the back side of their hip. And then I want to go over what minimally invasive treatments can be, including hip arthroscopy and also anterior hip replacement, and kind of compare that to other types of hip replacement. So if we start with the anatomy, the hip is a ball and socket joint, and one of our or some of our terminology is going to be that the socket is the acetabulum and the femoral head is the ball. And if we kind of look into the joint a little closer, there are cartilage structures. So wherever our joints come together, there's a layer of white cartilage that protects the bone. And this is called articular cartilage. The hip has another layer of cartilage around the socket called the labrum. And that's a little bit different. It's kind of a more rubbery type of cartilage that has some ligaments that attach to it. Muscles that might be associated with hip pain: deep in the front, the hip flexor is the iliopsoas. Off to the side, the gluteus medius or maximus muscles can cause pain, and the IT band, which itself isn't a muscle, but it's a band of tissue that holds the muscles together. And then sometimes people will actually get pain around their hip from nerve conditions, and primarily the sciatic nerve. So this is a back view of the hip joint area, and as you can see, the sciatic nerve comes down right by the back side of the hip. Another type of tissue that can cause pain is the bursa. The bursa is a normal fluid-filled cushion our body has over bony prominences. There's one where we sit down on the ischiotuberosity. There's a bursa deep in the front of the hip. And then the one that really causes most people pain is off to the side, and that's the trochanteric bursa. When the bursa gets inflamed, it's referred to as a bursitis, and that tissue can be very boggy, very swollen, and be a source of pain. So these are some of the common causes of hip pain, all the way from bursitis, tendonitis to tendon tearing. Hip impingement we'll get into. It's where some irregularity of the hip shape causes things to pinch and often is associated with a labral tear. And then a couple terms for sciatic nerve irritation include piriformis syndrome or deep gluteal syndrome, and then hip arthritis. So we're going to touch on these. And again, I kind of wanted to separate these based on where someone's hip hurts, because a lot of times someone will come in to the office and they'll say, oh, my hip is killing me, and they're pressing right here, and that is part of the hip, but it's not actually part of the hip joint. So as we see on this diagram or the picture on the upper right, the hip joint is kind of deeper towards the groin, a little bit more around the front, whereas off to the side we're dealing with the trochanter, which is the bump where some muscles insert that are often tender, or sometimes pain deep in the buttock area might be related to something other than the hip joint. So we'll start with pain in the front of the hip or the anterior hip, and things that I think about are hip impingement, often associated with a labrum tear, hip flexor tendonitis, or sometimes arthritis. So this is a big word, femoroacetabular impingement, but basically it just means hip impingement. It's the femur and the acetabulum to form that big word. And if anybody is developing hip pain, especially younger in life, we always get concerned that maybe they have a change in their anatomy shape. And some people, for whatever reason, when they have a growth plate at the time their hip is developing, may end up with some extra bone, and that extra bone can lead to some incongruity of the joint. And based on different motions of our hip, that might cause some injury. So this is a normal hip joint, and if you look at the shape of the ball, it's contoured, so it kind of looks like a light bulb. If someone has hip impingement, they may have extra bone so that it doesn't have a nice normal taper when someone's moving their hip around. This is a cross-section view of what that looks like. This is a normal hip, nice round ball. It tapers on either side. If someone has too much bone on the front of the ball, that's a cam lesion. If someone has too much bone on the socket, that's a pincer lesion, and some people may have both. Why this is important is because this is associated with developing arthritis or breakdown of the hip joint. So if we look at research studies that have evaluated people that have a different shape, and this is actually a picture of a surgical dislocation of the ball of the hip joint, and it's round, 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 and then someone has extra bone here. And as the years go on and we move our hip around and that more oval shape is driven into the socket, it starts to break down the cartilage of the labrum and the cartilage of the socket. And that's what can lead to arthritis. Why that's important is because the hip joint really isn't a wear and tear type of joint. And what I mean is sometimes people develop arthritis of their joints, like their knee joint, maybe their shoulder, and anatomically there's no different shape, there's no differences to a joint that hasn't developed arthritis. But if we look at the hip, either someone has too much bone or their hip socket is too shallow, and that's 90% of the people that get hip arthritis. So there's some anatomic shape difference for those hip joints that develop arthritis. So in orthopedics, it's kind of stated that this is really not a wear and tear issue of the hip, it's more of an anatomical shape. So too much bone where things hit and bang and cause damage, or a socket that's too shallow and it doesn't cover the ball in a safe way to allow stress to be distributed. So our goal, at least my goal when I see hip pain, is to try to identify hip impingement pathology if that's where someone's having a problem, so that they don't end up with hip arthritis, and so we can avoid a hip replacement. So that's an x-ray of what a hip replacement looks like. So again, hip impingement, we're worried about pain in the front. Some teenagers present with this, but people throughout pretty much all the decades of life can start developing some groin pain, pain in the front of their hip, and we always get concerned, well, is this hip impingement? So things that involve hip flexion can aggravate the pain. Often someone will say, oh, my hip hurts, and it's this C sign. So they have pain from the front to the back. Most of it tends to be deep in the front, deep in the groin area, because again, that's where our hip joint is located. From my point of view, we can run the hip through some different tests, typically with flexion of the hip, rotation to aggravate the pain. If someone's really inflamed, we don't even have to have the hip flex. Just rotation alone will aggravate their hip pain. And again, different tests we can look at. One of the first things that I do is we want to get an x-ray. We just want to see what is the shape of the ball in the socket. And there's different things I look at. And I just want to comment that, again, this is kind of an outline of a hip socket that has too much bone overhanging it. So that's a pincer lesion. And then we can get regular x-rays or CT scan that shows if someone has too much bone around the ball. Again, these are things that can lead to too much contact pressure and cause injury. The labrum is the type of cartilage that usually gets injured first with this condition. We can't see the labrum on an x-ray because it's soft tissue. So sometimes we get an MRI scan and the labrum should be a little black triangle that attaches to the edge of the socket. And on these images, there's white fluid that leaks in to what should be a solid triangle. And that's what a labrum tear looks like on the MRI scan. So this is what we want to educate people about. mainly healthcare professionals, to make sure that they understand when someone has hip pain that maybe they have to consider everything, because this isn't an uncommon story that someone tells me. They go, oh, I saw Dr. So-and-so and we got an x-ray and everything looked fine, so I'm not sure why my hip hurts. But a lot of doctors, you know, you have to be thinking of something to make that diagnosis. So a lot of people, when they look at an x-ray from a healthcare point of view, they go, oh, well, there's a hip joint space, that's where our cartilage is that coats the bone. Say, well, doesn't look like bone-on-bone arthritis, so your hip must be okay. But if you look at this from my point of view, we can see obviously it's round, tapers nicely here, but this part's round, and there's no taper here. So this is a classic CAM lesion of someone that has hip pain. And if we compare it to what a normal x-ray looks like of a hip joint, this is potentially going to lead to hip arthritis in someone that it's hurting, especially younger in life. So, to kind of see that a little bit further in terms of the detail of how does that bump when we move our hip, how does that cause injury? Again, we've got the ball, we've got the socket, and then the labrum. And the labrum merges with the articular cartilage deeper in the socket. So if I've got more of an oval shape to my hip femoral head, the labrum looks like this from the outside, and as we pull traction on the hip joint, we can start to see under the labrum, and here's where the injury occurs, deep in the socket. So I have to pull traction on the hip joint to see what's going on in the socket, and the bump that people have, which is a CAM lesion, rubs into part of the hip joint. It causes tearing of the labrum and breakdown of the cartilage of the socket. So that's how it leads to arthritis. Problem is our body doesn't make new cartilage once it gets worn down or injured. So we don't want this process to go on for a long time if someone's in pain, because we can get to the point where we don't even see cartilage. There's just exposed bone right there. The other interesting thing for the hip is that the labrum can sometimes turn to bone. So occasionally we see someone that's had hip impingement for a long time and they actually start to ossify their labrum. So again, we don't want to lose normal structures, the kind of the rubbery shock absorbing function of the labrum, because it's turning to bone. So how do we treat hip impingement? Well, like most things in orthopedics, we always start with kind of easy things, medications, rest, heat, ice, physical therapy. But unfortunately, if this is a mechanical thing, like someone has too much bone somewhere, we can't always get to the underlying cause with kind of easier things. So sometimes we have to try to recontour the bone, but we'll go into that a little later in this talk. So now we'll go to pain on the side. So someone comes in, they says, oh, my hip joint hurts. And often, again, this is not the hip joint. This is going to be a little bit more of what's out there. So we're concerned about a bursitis. We're concerned about the iliotibial band. We're concerned about some of the tendons, mainly the gluteus medius and minimus. And they can be inflamed, or in some people, they can actually tear. This pain tends to be aggravated by someone just putting pressure on the side of their hip, right where you have that bump. That's the greater trochanter. So if you have a bursitis or inflamed tissue, that will aggravate the pain. Again, straightforward treatment. Most of these conditions on the side of the hip will get better with therapy if they can stretch the IT band, maybe some anti-inflammatory medications for a while. Sometimes injection with steroid to help with inflammation, sometimes hip arthroscopy. Someone comes in, they say, my hip hurts, and they put their hand back here and they press to their buttock. This is kind of a tough one because there's a lot back here that can cause pain. So if we look, the sacroiliac joint, the low back, these are things we want to rule out because, again, most people with actual hip joint pain, it's really a lot of deep groin pain. This pain, it can be the hip joint, but we want to make sure it's not the low back, We want to make sure it's not the sacroiliac joint. And if it radiates down the leg, that tends to be a little bit more like the sciatic nerve. Now, the sciatic nerve can be irritated in the low back, or it can be irritated commonly where the piriformis muscle can put pressure on that nerve. So some people use the term piriformis syndrome. The thing is, that's only one muscle or one thing in that area that can put pressure on the sciatic nerve. There's other structures back there, but this is fairly common term still. And here's what we're talking about is the piriformis muscle comes off the sacrum. It inserts on the back side of the greater trochanter, and you can see the sciatic nerve comes out in terms of its anatomy from underneath the piriformis muscle. So anything that affects the piriformis muscle might put compression on the sciatic nerve. So if we have someone that's real athletic and running, that muscle may get hypertrophied. It may put pressure on the sciatic nerve. Some people have pressure in that area, thick wallet, something like that. Or if you fall, if you slip on the ice and you come down on your buttock region, some people get a really big hematoma. It fills in with scar tissue, and it can end up putting pressure on the nerve. A lot of these conditions can be improved with therapy, with working out the muscles in that area, occasionally injections. Sometimes fancy things, even like Botox, can be injected into the piriformis muscle to kind of shrink it a little bit to avoid pressure on the sciatic nerve. And then there's some hip arthroscopy options too. Hip arthritis, this is a condition where that smooth layer of cartilage that coats the surfaces of the bone is wearing down. What our articular cartilage does is it protects the bones where they come together at any of our joints. So if that wears down, the bone isn't protected anymore, the bone is innervated, people feel the pain, the body starts to thicken the bone around the arthritic joint, so motion is lost, and the body can't make new cartilage, so the condition just gradually worsens. If we look at an x-ray of someone with hip arthritis, this is the normal side. We have a nice round ball. We have a good space here. This is an arthritic hip. So we have very little joint space. We have cysts in the bone, which is a reaction to the stress from not having cartilage to protect the bone. There's extra bone formation all about the hip joint. And when you have that extra bone forming, you just automatically lose motion. So again, as arthritis develops in a hip joint or any joint, the motion is lost. And if the process goes on long enough, the joint can actually fuse. So hip arthritis, again, the whole area around the front to the back may hurt. It's often aggravated with anything that causes rotation of the hip. A lot of people talk about they can't get down to put their shoe on or take their sock off. It gets that difficult to move the hip. Treatments for hip arthritis, especially early on, a lot of just activity modifications, maybe heat or ice or physical therapy to work on balancing the shock absorbing muscles around the joint, stretching some of the ligaments that contract early to limit motion can be worked on. Injections, there's a variety of injections. Often we start with a steroid to kind of calm down inflammation. Sometimes we use lubricant shots. There's a whole industry now of stem cell injections. Unfortunately, we don't have any real proof that it grows cartilage in a joint that's arthritic. It might make a joint feel better, but we really don't know the mechanism of that yet. Hip arthroscopy for minor arthritis changes, and then a hip replacement if it's too advanced. So now I want to go over hip arthroscopy, and again, this is one of the minimally invasive treatments for hip pain. So arthroscopy is doing surgery through small openings. So this is a thigh, and typically hip arthroscopy is done through usually 2, sometimes 3 little openings. Through one of the openings, a camera is inserted, probably a little bit less diameter than a standard pen, and then through the other opening, special surgical instruments can be placed. And this is a breakthrough because for years no one did hip arthroscopy. We did shoulder arthroscopy, knee arthroscopy, but hip surgeries, like early surgery to take away hip impingement, were done through big openings. The hip was dislocated, extra bone was taken away. But this is a really big procedure to do that if it could be done arthroscopically. So again, this is what hip arthroscopy looks like, a little camera through a little opening. If we're doing bony work, we often have an X-ray machine in the room to make sure things are looking how we want, especially if we're contouring the bone. We often apply some traction to open up the hip joint, but then we can see directly the labrum, the articular cartilage, the shape of the ball in the socket. So hip arthroscopy has really expanded what we can do and what we can treat about the hip without making big openings. So these are a whole list of things that we can treat, and I included some videos because they're kind of interesting to look at. This is our goal. Again, this is someone that's got a cam lesion, hip impingement, and if we can look at that at the time of arthroscopy, we can just smooth away this bump, and that's what it looks like. If someone has too much overhang from their socket, we often have to detach the labrum, smooth away the extra bone, and then reattach the labrum. So this is kind of a standard treatment right here. Here's the labrum. We've smoothed away the overhang, the pincer lesion. Then we repair the labrum back with stitches, and where the bone had too much head-neck prominence, we smooth away that also. So this was a case a few years ago. This was a young guy, 38 years old. His father had had a hip replacement in his early 50s. So he had a family history of something going on with the hips, and he was in a lot of pain without responding to conservative treatment. So this is what hip arthroscopy looks like. So this is the labrum in this gentleman. And it's all kind of beat up and torn. And this is what happens when things pinch. If we look deeper in the hip socket, you could see a little bit of like a loose fragment that's broken off. The joint's getting some arthritis here. So if we had picked up this condition sooner, maybe we could get rid of the bump, get rid of the pinching that has caused that injury. I can repair the labrum, but we can't really make new cartilage that easy. We have some techniques, but nothing as good as what we start with. So in his case, there was a combination of a pincer lesion, and this was, again, the overhang from the acetabulum. So what we do is we clean up with a little shaver the torn labral tissue. And then what we have to do is get the labrum off the overhang of bone, and we expose that bone that's too much. And then I take a bone burr and we just kind of smooth that overhang back. So here I'm still cleaning off the soft tissue, but then we take a bone burr and smooth away that extra bone. I have an X-ray machine in the operating room, so we know exactly how far back we want to smooth it. After that, we have to repair the labrum. It was becoming detached anyway. We have little suture anchors, and this is an older video. Now we have suture anchors that are all suture material, so don't really have implants. So basically this is a repair of a labrum. We have special little instruments. I can pass things around the labrum, and again, instead of having to openly dislocate a hip to repair this, we can, tie these sutures arthroscopically, secure them down, and then the labrum will heal back to the bone that we had to smooth away the excess overhang. But what caused all this problem, again, was the bump. So the cam lesion on the femoral head neck. So here's the labrum repair, but all this is the extra bone, and that's what it looks like. And I'm just outlining it with my shaver. So it's this extra bone that someone developed probably their teenage years when they had an open growth plate in their hip, that we want to smooth that down and contour it. And again, I can just take a bone burr, take that away and contour it. Yeah, go ahead.
Do the sutures dissolve?
You know, the healing process is so slow in terms of soft tissue healing into bone, we have to use permanent sutures. Those stitches actually stay. And that's similar for rotator cuff. We tend to use non-absorbable sutures. So if we look back in the future, those stitches look the same. They don't change much. So this is what the difference looks like radiographically. So before, we could see the bump here. After, we've got it's round, then it contours. So that's what it looks like for hip impingement. More recently, we see people that have had a hip replacement, and sometimes their hip replacement hurts. When someone comes in that's had a hip replacement and they say it's starting to hurt, we're always concerned, well, is it getting loose? Is there an issue? We do some tests, but sometimes everything looks okay. And a newer condition that we seem to associate with some people is that their hip flexor tendon can rub over a part of their hip replacement and cause pain. So this is hip arthroscopy to try to treat that. And so the anatomy is such that when we put a hip replacement in, if the front edge of the socket is a little proud, then sometimes the hip flexor tendon will rub over it. So the back side of the cup has this matted, irregular, rough surface, so bone grows into it. But if that's a little proud, the hip flexor tendon can rub right over that and cause pain. Now in the x-ray, we can't really see that because it's soft tissue, but this is our concern. A little overhang, and some people will have pain when they lift their hip up, even though the hip replacement looks okay. So arthroscopically, we can help this. So this is a case I did a few months ago. You could see that roughened surface that's a little prominent, and then here's someone's hip flexor tendon, and you can see it's kind of abraded. And if I move their hip through range of motion, you can see how that tendon rubs right over the cup of a hip replacement. And that just won't go away, the pain. Interesting is if we just release that tendon, it will grow back lengthened. So this is a radio frequency wand, meaning that little tip there generates heat, and I can take that little wand and touch it on the tendon, and it just releases the tendon. Now, the hip flexor tendon will grow back, but it will grow back lengthened, and so it won't rub as tightly over that. Anyway, that's great because for years, sometimes we would revise a hip replacement cup because it overhung a little bit. Now, sometimes we can just treat it fairly easy. Yeah.
What would be like precautions then after that surgery for like them?
You know, the main is just that for a while their hip is weak, so that they might lift their thigh up, but that seems to come back pretty quick within. So no real precautions. It's not like repeating hip precautions after a hip replacement. So pain on the side, and someone, so they go to physical therapy. Most people get better. Stretch the IT band, because again, the IT band is this thick layer of fibrous tissue that covers our muscles. And we think sometimes if it's too tight, it can get the bursitis under it, and it can be a source of pain. So this is only a case for people that can't get better with kind of conservative treatment, therapy, injections. So what we're going to do is a technique trying to window or put a kind of a opening in the iliotibial band so it doesn't rub over the bump. And that's what this video is showing. So we're outside the iliotibial band, very thick tissue, and we can use this radio frequency wand to make a split in the band. And this split, the patient's on their kind of their backside, so it's inferior going to superior. And under this is where the bursitis is. And again, if the IT band is too tight, it's hard to get rid of the bursitis without getting this to stretch. Now we release the IT band this way, and again, we kind of make a windowing so that there's less friction when someone moves or rotates their hip. And this is what bursitis looks like, this red inflamed tissue. And so what we can do is insert a shaver and clean out that bursitis. Again, if someone doesn't respond, so this is a shaver, and we can clean out that thickened abnormal bursitis tissue. Now, some people, even without a trauma, can develop a tear of some of the muscles that insert here. So a lot of times I see people and they go, oh, I've got this bursitis, I've had it for years and years, and you know, after a while, most things should get better. Maybe they're inflamed for a while, but sometimes people will actually have a tear of that tendon. And so we can often see that on an MRI scan, but this is an interesting one because, again, some of our gluteus muscles that come off the pelvic wing, they insert as a tendon around the greater trochanter. So again, if someone has a lot of pain there and it doesn't go away, this is what the tear looks like. So this is hip arthroscopy. This should all be attached. This is gluteus medius tendon. You can see how it pulled off the bone. And on its own, it's hard for our body to get that back. So I take a little burr, I want to freshen the surface to get a healing response, like make it bleed a little bit. This is a suture anchor that with time will turn into bone. It's an absorbable one. So this is how we can repair things that have pulled off of bone. This is a triple loaded suture anchor. And so when I take the inserter off, here's the stitches. And they're different colors, which helps me not lose sight of what stitch goes with what stitch after we pass them. I've got special instruments to pass the stitches through the tendon. So basically, we just want to weave the stitches through the torn tendon on the left. And as we pass stitches, we have, again, all these special little instruments to grab them, take them out outside of the body. And then I've passed one limb of the suture, and then back here I can pass the other limb of the suture. And again, this saves any big opening over the hip. So that's what suture passage is like through the tendon. And then after I've done it with the black and white suture, I do it with the other colored sutures. And then this is what it looks like after I've passed all the stitches. And then we just go on to tie them. So after I tie them, this is the first stitch has been tied. And now I'm going to just go down the row, and now I'm going to tie the blue sutures. And again, we have fancy knots that we can tie arthroscopically. And again, you can see how tying the stitches pulls the tendon back into the bone where it was detached. And now if we can give it a couple months, it heals into the bone. So someone has to go fairly slow to let this heal, but that's how we treat those injuries. And then the sciatic nerve. So again, if we've ruled out that the sciatic nerve is not being irritated in the low back, and that it truly is isolated to outside of the back area, then we can consider, if someone's still having a lot of pain, exploring the nerve. So this is arthroscopy around the sciatic nerve. This is what the sciatic nerve looks like right here. This is deep in the back. And what I want to do is just free it up. So I take a blunt probe and I free up. This is what the nerve looks like after I clean any adhesions off it, scar tissue. And as I track up towards the piriformis muscle, which is up in this area, I can see this band. This is part of a tendinous band of one of the smaller muscles back in the hip. So that's putting pressure right on the sciatic nerve. So what I can do is just, again, for a lot of these tendon issues, we can just release the tendon. The body will grow it back lengthened. So here's my little radio frequency wand. I can release that tendon. And then it's just red muscle fibers, which are actually very soft compared to the tendon. So the nerve has freedom then. So again, hip arthroscopy is interesting because all these disorders before that we had to do kind of bigger open procedures for, we can get to with just 2 or 3 little openings these days. Now, hip replacement for hip arthritis. The whole idea is, again, arthritis, you lose that smooth cartilage protection of the ball and socket, and this is an artificial way of restoring a smooth ball and socket. Part of the implant goes down the shaft of the femur. Part of the socket implant goes into what used to be the original socket. It does involve removing the arthritic ball and then preparing the socket to accept a new metal socket. There's a liner of usually polyethylene, which is like plastic, and then we put a metal ball or a ceramic ball, and that's the new hip joint. People that have bad hip arthritis have typically very good pain relief. They can get back to doing things that for years they hadn't been able to do. And most hip replacements will last about 20 years or so. Probably longer with some of the ceramics that we're using now. So what do you expect after surgery if someone has a hip replacement? Everybody's different. So if I've had someone that's been out of commission for years and years with bad hip pain, and all their muscles have atrophied, it really takes a longer time to recover than someone that's addressed this a little bit sooner. So everybody's different, and this is why we see some people come into our office the first week after the hip replacement without crutches or a cane or anything. They just walk in. Other people are still on a walker. So everybody's a little bit different, but there's some period of protection. We just don't want people to fall. So whatever helps people feel stable, whether it's a walker or a cane or crutches. But after the first month or so, people are really making a lot of progress. They can walk as much as they want. Slowly the muscle recovery continues, even up to a year. And most people get back to doing what they want to do. There's people that ski, snowboard. Some people ask me, can I get back to jogging? And you can, but I just, just like a normal hip wore out, a hip replacement can wear out too. So I still recommend, if possible, people try to avoid the real high impact things if they're going to do that on a routine basis. Hip replacement techniques. So there's different ways we can do a hip replacement in terms of the approach. Now, the actual replacement of the ball and socket is the same. It's just how do we get to the hip? So we can get to the hip from the front, anterior from the side, lateral or posterior from kind of the back side of the buttock region. From a surgical point of view, it's just which way do I want to go? What are the risks of going that way, and what are the benefits of going one way over the other? So if I go and I do a posterior hip approach, which is probably the most common way hip replacements are done in the United States, I typically have an opening that kind of curves towards the back side. As a surgeon, I have to go through some things to get down there. So the gluteus maximus is our big buttock muscle, so I have to split into that. And then as we go deeper, there's some other muscles I have to go through. If I go from the side to do a hip replacement, I have to go through part of the gluteus medius and the minimus sometimes. If I go from the front, I can get between muscles, and I don't really have to cut any muscles. So just to show a little bit more detail, if I do a posterior hip replacement, someone's typically on their side. This is the standard approach. We have to go through some of the gluteus maximus fibers. We repair this at the end, but it makes everything exposed. We can see everything. And then after I go through this part, I have to detach the piriformis muscle, some of the short external rotators, and again, I repair those at the end. The sciatic nerve's right in that area, but we typically see it when we go from this approach. If I go from the side, Again, I kind of make an approach where I have to get through some of the gluteus medius muscle, some of the vastus lateralis, which is part of your quadriceps muscle. So we get an opening that I can then dislocate the hip. Again, at the end of the case, these are all repaired. If I go from the front or anterior, the anatomy is such that I can spread the muscles apart. I don't have to cut them. And by putting retractors around, we can get right down to the hip joint. So the benefit of going from the front is that we typically can use a smaller incision because we're doing things in a way that by spreading the muscles, we don't have to have a larger approach to go through so much thickness to get down to the hip joint. It's more direct to go to the hip joint from the front. What do I think about when I'm recommending a hip replacement to someone? What are our concerns? What might go wrong? What are some potential complications? Well, one of the issues is after hip replacement, some people might have an episode where their hip comes out of the socket. That's called a dislocation. And usually it's just early on, like while we're trying to wait for things to heal. So if I do a hip replacement and I stitch things together, I want people to be careful because until things heal, the ball could come out. And that's an x-ray of what that looks like. Probably the highest risk of that is if I've done the surgery from the back. And the reason is because if my hip is flexed, like when I sit down, it puts stress right on the area where the surgery went through. So we always get a little bit worried with positions that people are in after their surgery. And so we want to make sure if we've gone from the back that people are real careful by not bending over too much. We want to make sure their legs are further apart. That tends to help keep the hip stable also. If we go from the front, we think it's a little less of a risk, that maybe we don't have to use some of these precautions. Because again, we're going through the front, and that doesn't come into play when people sit down and we haven't cut things that we have to repair. So it seems like there's a lower instability issue after anterior approaches. Other concerns are leg lengths. So whenever we do a hip replacement, we can alter the length of your leg. And the tendency is usually to make a leg a little long if it goes one way or the other. Most people want equal leg lengths, and that makes sense. Occasionally the surgeon may feel like the hip's unstable and it feels tighter if we lengthen it. Ideally though, we don't want to have to do that. We want to get people matched, okay? So if I do a hip replacement when someone is lying on their back, it's easier to measure things than if they're on their side. And again, if we're doing the hip replacement from the front, we often and typically have an x-ray machine there so we can easily just measure the leg lengths with the x-ray machine, and the patient is lying there flat, very symmetrical as opposed to on their side, and we actually reference a line just like this. And we measure where does that line, if I put it on the lower part of the pelvis bone, meet the lesser trochanter. And if it's lengthening it, we can shorten things. If it's too short, we can lengthen things. So basically, this is how we measure leg lengths. We actually do it with an x-ray machine in the operating room, trying to match exactly what we want in terms of the person's length. We're always trying to get someone going quicker. So if we can avoid postoperative weakness, we don't have to worry about limping so much. And again, if we can avoid going through muscles that we have to cut and repair, I think it's easier on people. So years ago I started doing this. I still do an occasional posterior hip replacement, but really I think there's a lot of advantages from my point of view if we go from the front. And in general, it just seems like the early recovery is quicker for most people. Again, the end result is the same. People are going to get good pain relief regardless of which approach is used. It's just, again, if we look at minimally invasive techniques, this is the one for a hip replacement. This is tends to be kind of a typical scar for someone if we go from the posterior to the backside. And especially on thin people, we can really get this small in front. Not that scar size matters that much, but if you have to pick smaller versus larger scar, it's nicer to have a smaller one. So in conclusion, there's a lot of things that can make the hip hurt. And as you've seen through all those pictures, there's a combination of muscles, tendons, bursa, cartilage injuries, even the nerve can be a source of pain. It kind of helps me to break down things based on the location where people feel their pain. But I would say, especially with anybody concerned about like a hip impingement condition, it sure is nice to get to that sooner rather than later, because once the cartilage in the hip is injured, it's sometimes hard to make that hip feel better for people. So, any questions? Anybody? Yeah.
Can the hip impingement also cause a locking of your hip area?
Yeah. So, I mean, often that's associated with a tear of the labrum. So once you get a tear of something, you get kind of a mechanical issue like locking or catching. That can occur sometimes with even just an inflamed hip flexor tendon though too. People will feel something pop or catch. But the more mechanical something is versus just pain makes us concerned that there's something in there blocking the normal smooth motion of the ball and socket, and it could be the labrum, which again is that cartilage around the socket. So.
And would you need an MRI or an X-ray to figure that out?
We usually start with an X-ray to see what the condition of the joint is, but if we want to see the labrum, if that's a condition of concern, we need the MRI scan. And occasionally, I have like ultrasound in our office. I had someone the other day, it was really, their hip was clicking and catching, and it was their hip flexor tendon. And by just rotating it, I could see on the ultrasound the tendon popping over the ball, because it's intimate, it's right on the front surface. So different things can catch, can lock. It really depends what we see, in terms of, is it your hip flexor tendon? Is it a mechanical thing from a cartilage injury or bony irregularity? So those are the common things. The other thing I didn't really talk about is occasionally someone gets a loose body in the joint that will click or lock up sometimes. So.
And what would that be?
Well, if someone's had, say, an injury or trauma, occasionally we get a little fleck of something that breaks off. But in the hip joint or the knee joint or the shoulder, it continues to get nutrition from the joint fluid. And so something that broke off tiny, with time will grow and become more of an issue. We see that if we have some injury to a joint, sometimes a scar tissue response happens, and so you can get thickening of kind of the synovial or the joint lining tissue. That can kind of click too. So different things can click and pop. But
You said that the hip replacement can last up to like 20 years, but you can't replace it with replacement.
yeah, so if a total joint replacement, whether it's the knee or whether it's the hip or the shoulder, one of the reasons a joint replacement wears out is that the bearing surfaces shed some particles, microscopic particles, that as the years go on, our body has this low-grade inflammatory response to those particles. And what that does around a joint replacement is it usually weakens the bone around it. So as the years go on, sometimes people will develop loosening, not so much the hip or the knee or whatever is worn out. It's just the bone around it has kind of melted away almost. And so what can wear out is the plastic liner, because that's where the particulate is coming from often. But I mentioned ceramics. We have, one of the issues with hip replacements can be some of the metal wear. And so if we use a ceramic ball, sometimes a ceramic socket too, the wear particles are as low as we can get it. And so some people are a candidate for that. And in those situations, we think maybe the hip replacement will last 30 or 40 years. Because again, we're kind of getting rid of what causes some of the loosening. So.